So we're gonna start getting back together for our last like 40 minutes together today. But I had a really great question brought to me during our break that I wanted to just touch base on again. I talked about this day one, but I think it's worth the review. And yes, I will try to post the recorded lectures from yesterday. It just takes me like, I have to upload them to YouTube and it takes a long time to upload them because they're very large files. So I have to do it on a day where I'm not in clinic. I think my clinic schedule is slow today, so I probably can get them up for you today. But one thing to keep in mind is the breakdown of the exam. So the exam, there's two sections. You have like an anatomy, kind of how the body's working when things are going right. And you have the how the body's working when things are going wrong. So your path section is going to be about 40% of your exam total. Your physiology section is about 60% of the exam total. You have to pass these two separate sections, both of them, to pass the exam. So in the path section, you have about 20% of that 40%. So about half your path section is on true pathology. What is this condition? What are the risk factors? What's the complications? What are pathognomonics, etc. Then 20% of the pathology section is on micro and immunology. And it can be on normal immunology, like the immune system when it's going right. So that is your path section. So 50-50 pathology and then micro/immunology. Okay, you have to pass that section on its own. Most NUNM students do good on that section overall. Then the bigger chunk of your exam, 60% of your exam is going to be on anatomy, which includes embryology, physiology, and genetics/biochemistry. So 20% of that 60%, so 1/5 of your exam will be on anatomy/embryology. 1/5 of the exam is on physiology, how things work in the body, and 1/5 of the exam is on genetics/biochemistry. Okay, you have to pass that section separately to pass the test. So when you're going through your practice exams, a good idea if you're trying to decide what to focus your study on next week for your last week before NPLEX, it would be a good idea to go through your practice exams and see which section am I struggling on. Am I passing the path section with micro and immuno, but I'm struggling on anatomy, physiology, and genetics and biochem in comparison? Or is there one specific section within, like maybe I'm a rock star in physio and biochem and genetics, but I suck with anatomy and embryology, right? So see kind of where you're at, and that can help you focus your study. Again, this last week, so next week of your NPLEX review, when you're not here with me, your best bang for your buck is to really lean into and nail down things that you kind of already know. So lean into your strengths next week and spend a little time learning things that maybe are high yield in the area of your weakness. So if anatomy is your area of weakness, spend some time learning some high yield stuff like the cranial nerves, cardiovascular vascularity. Maybe know if muscle action stuff is easy, put those in your brain. Whatever is high yield that you can get into your brain in your weak area next week, do that. But don't necessarily try to learn all of it next week, right? Lean into your areas of strength and focus on some high yield areas in your weakness. That would be my suggestion for you next week. So now we get to the musculoskeletal section. I have posted 4 MSK PowerPoints. The MSK PowerPoints are going through all of your muscle actions, insertions, origins, and innervations. We're not going to spend a lot of time on those today. I'm not going to go through all them in class for you. That's going to be memorization you can do on your own time. But I will kind of try to hit a couple groups for us in class. And then we're going to do a little bit of MSK Path. I have curated down these PowerPoints since posting them. So there are some slides that are in your PowerPoints that I have deleted. So just keep that in mind when you're following along at home. All right. So the first one I'm in is just the muscular system, number 1. This is the first PowerPoint from current slide. So big pieces in this presentation, I'm going to skip through a lot of stuff here, but for naming, if you're having trouble remembering muscle names, remember oftentimes the muscle name is going to help tell you the muscle location with the bones. This can help you with anatomy questions. It also will tell you often the shape. So deltoid is a triangle. And they'll also often tell you the size, right? Minimus, maximus, or longus. It also will sometimes talk about the type of fibers or fascicles, which can help you talk about the action, right, that the muscle is doing, or the insertion or origin. So if it's a rectus, the fibers are going to be running straight. Transverse, they're running at right angles, or oblique, they're running at like kind of almost diagonal angles, or biceps, triceps, multiple origins. So remember, use these names to your advantage and logically think through. If you haven't put these to memory, logically think through what these muscle names mean or what they could be associated with. As I promise you, you will not have every muscle. Well, maybe you will, but most people don't have every muscle's origin, insertion, action, and innervation memorized by the time you go into this test. It's just not realistic. Also think about actions. If there's a certain action that can help you with the attachments, you might not be able to think in your brain of origin and insertion, but you'll at least know general attachment points depending on the action of the muscle. So use these logical pieces and feel free to move during your test. This goes through if you forgot what muscle arrangements are. I'm skipping this for now, but if you want to remember, this talks all about what muscle arrangements look like, pattern recognition, et cetera, et cetera. And so now we're all the way through on slide 23 of 59 at the major skeletal muscles of the body. This is where we start getting into the nitty gritty. And then we get into muscles of the head and scalp. So muscles of facial, these are the charts I've included for you. So it's going to show the muscle here in one category, the description of that muscle, the origin and insertion, the action, and the nerve supply. If you wanted to commit one thing to memory, two things to memory, be the muscle action and the nerve supply. If you can do those two things first, that would be great. If not, fine. Don't deal with it. Not going to be your high yield. Origin insertion will be last. That would be the last thing I'd connect to memory. There will be some origin insertion questions on your test. And like, if that's not where your brain is, that's fine. A lot of times your action can help you decide where the origin or insertion is from what answers they give you. So I'm not going to go through, like I said, these step by step. There's some groups I want to talk about. So I do give you some cadaver pictures and some basic kind of normal pictures. But groupings is what I find to be most important. So a grouping that we can keep in mind is all of our muscles of mastication, right? If we can have questions that involve not only anatomy, but physiology, NPLEX is likely going to pull from there. So being able to make these groupings for yourself will be helpful because they might ask you a question of, these are all muscles of mastication except, right? So if you're able to do these groupings for high yield study, this will help you in the long run. So these muscles of mastication are all innervated by the cranial nerve 5, right? 5. The major movers of jaw closure is your temporalis muscle right here, and your masseter. Your grinding movements is your pterygoids, and your big chewing roll is your buccinator, depending on who you talk to. Then you have muscles that promote tongue movements, 3 muscles that do this. Your genioglossus, your hypoglossus, and your styloglossus. Great, they all have glossus on them. Fabulous. So these 2 groupings would be important to know and commit to memory, especially because the muscles of mastication all have a shared cranial nerve. So if we do something where we sever that cranial nerve, what muscles do we affect? And then they might give you a list of muscles, or what action would this affect in the body in its mastication? What process of digestion would be affected if cranial nerve number 5 was severed or was atrophied? Be mastication, right? So you can see how these questions could be used. Groupings, important. And then here's your list of what those muscles are, but I like pictures. So here's your temporalis, your masseter, your buccinator. You even have your orbicularis oris, which we didn't talk about before. And then deeper, you're going to have your pterygoids, your lateral and your medial. You have to pull away the masseter to access your pterygoids. So then they list the muscles of the tongue. All of these are innervated by the hypoglossal nerve, which is cranial nerve 12. So that's another fabulous cranial nerve association. We will talk about cranial nerves tomorrow in more detail. But you have or Thursday. I keep saying tomorrow. I pretty much skip Wednesdays now and just associate my next day being here with you all. I teach somewhere else on Wednesdays. So we have our genioglossus, our styloglossus, and our hypoglossus, all controlling the tongue. Another grouping, muscles of the anterior neck and throat that help with swallowing. So this is another important grouping to keep in mind. You have your sternocleidomastoid. Oh, thank you. Telling me about dysphagia. Sternocleidomastoid, you have two kind of muscle groups divided based on location to hyoid. You have your anterior group, your suprahyoid group, and your infrahyoid group. So your suprahyoid group above the hyoid bone involved in swallowing is going to be 4 muscles. These are their actions. So all of them are forming the floor of the oral cavity. They anchor the tongue, they elevate the hyoid, and they move the larynx during swallowing. So this is your group, your digastric, your stylohyoid, your mylohyoid, and your geniohyoid, which is great. They all have hyoid in them except for the digastric. That's the one that's different. They are not all innervated by the same nerve, so it doesn't help you here. The big helpful thing is they're involved with swallowing, and they're all above the hyoid bone. Those would be your helpful connotations. Your infrahyoid bone are strap-like. They're going to depress the hyoid and the larynx during swallowing and speaking. So your infrahyoid is going to be your sternohyoid, your sternothyroid, your omohyoid, and your thyrohyoid. And we'll see a picture here that'll have the omo, the thyro, the sternothyroid, and the sternohyoid. So here's all your muscle, your pictures. If you're a visual person, you have your suprahyoid and your infrahyoid muscles. You can see here's our hyoid bone, the muscles above suprahyoid, your muscles below infrahyoid. So we have our digastric here and here. We have our stylohyoid, which is cut, which is actually, yep, right there. We have our mylohyoid and our there's the stylohyoid over here. Below, we have our omohyoid, our sternohyoid. We can't even see all of them here. We can see the sternothyroid and our thyroid gland and tissue. You want to see on the cadaver, again, you're not going to have to memorize it based off of appearance for this test. There's going to be no pictures, so no point in looking at a cadaver for this exam. I would look at your nice, pretty, easy to tell pictures. You're going to have to describe them. That's why things like above the hyoid and below the hyoid is going to be your best bang for your buck. You have two kind of head, neck, and muscle movement groups. You have your anterior lateral neck muscles, which move the head, and your intrinsic muscles of the back. I'm not going to worry about those right now for you because they're just basic movements. So we are going to skip through these because I want to get to muscles of respiration. We've talked about these before. I know we're flying, but that's where we're at. So muscles of breathing, we have muscles of inspiration and expiration. These are easy grab questions. So you have your external intercostals, your internal intercostals, and your diaphragm. So those are your big muscles of respiration. Again, from a different view, external, internal, and diaphragm. So when expiration has to be active, these are the accessory muscles we recruit. That's where these questions could come into play. Your abdominal muscles, again, another group that's really easy to ask questions about because they have different locations, right? Your rectus abdominis, your external obliques, your internal obliques, and your transverse abdominis. Creating that trunk, all innervated by intercostal nerves. They all have a similar innervation site. So you can see here, again, I know it's a tiny picture, but you can zoom in on your screen. The intercostal nerve innervates all the muscles of the abdominal wall. And if you're visual, here's your picture. Your rectus, your transverse, your internal oblique, and your external oblique. If you want to see them from a different view, this is a really good way that shows the muscle fiber structures and the direction of the fibers, which can help you remember the muscles themselves. The pelvic diaphragm muscles are often confusing and can be confused. If this isn't an area, if you're not strong in anatomy, I would not waste your time learning these muscles of the pelvic floor, but there will probably be some questions on it. So if you're strong in anatomy and like this stuff, this might be a high yield section for you. If you're struggling with kind of the basics for anatomy, I wouldn't go here, okay? Because it's a lot of different small muscle tissues. If you needed to know some muscles, any muscles that are involved in sphincters that can control things like urination or stool, those would be the helpful muscles to commit to memory. So again, peritoneum muscles, we have them all, male and female anatomy. I'm just moving through for now just so we can get hit the high points today. Then we're going to move to path here in a minute. We move through the muscles of the upper arm, the scapula and arm. The muscles of the shoulder girdle are going to be by far more important. So if you're going to do one upper extremity area, I would focus on the muscles of the rotator cuff and the muscles of the shoulder, that will be in PowerPoint 3, and then lower extremities in PowerPoint 4. But for our purposes, I want to move over to some pathology. So we will slow down, lean in, and talk about our MSK chronic conditions for a little bit. So our chronic musculoskeletal conditions, we can kind of see a nice overview picture here. So we can see mobility causing issues that can affect all these different areas. And we can see a nice little picture of a bunch of our different pathologies that can be associated with the musculoskeletal system that are chronic in nature. Starting with disc degeneration. So pads of fibrocartilage between our vertebrae are going to start to degenerate. In normal states, this resists spinal compression. So in pathologic states, you're going to see more compression of the spine. You can decrease movements. You have less mobility then of the spine. Typical etiologies can be normal wear and tear or any arthritic condition. You also could have a genetic component too. Common symptoms are going to be pain in the back, maybe spreads in a sciatic-like pattern to the buttocks and upper legs, and numbness or tingling in the lower extremities. Different from a herniated or ruptured disc, this is actually due to disc fluid leaking out. And this can also impinge and irritate nearby nerves. You're going to have, again, back pain, sciatica-like symptoms, decreased mobility. Risk factors here, a common one could be heavy lifting, bending, twisting, smoking, and also genetic factors. They love asking about nerve compression syndrome. So talking about a patient who has a history of a ruptured disc or herniated disc and is experiencing numbness and tingling in this specific location. What dermatome or sacral or lumbar nerve root is associated? So that's how those type of questions typically are answered. Or if it's a condition that wouldn't cause nerve root compression, then maybe you're looking for something a little bit more downstream or none of the above, right? Most of the time though, they want you to get those nerves. Yes. Those questions are more common with lower back, although you could see them with some cervical root compressions. I normally see though, if we're dealing with upper extremity, them talking about like median, radial, and ulnar nerves. So stuff that's more localized to kind of hands and distal upper extremities versus our like lumbar radiculopathy type questions where they can ask about all the way down to the foot and above from either like the sacral or lumbar nerve roots or dermatomal patterns. So both. And we will hit that tomorrow. We are going to talk about a decent amount of neuroanatomy tomorrow. Your most common locations for a herniated or ruptured disc are C5, C6, C6, C7, L4, L5, and L5S1. So those transition zones, more commonly associated. By far, low back is more common than upper back, but they can both occur. A big complication would be cauda equina syndrome you'd want to know about, saddle paresthesia, incontinence of bowel and of urine. Spinal stenosis, this is actually our narrowing of our spinal column. You can see this with the vertebral bone degeneration with normal aging. It's typically very insidious. It's slow onset with numbness, weakness, cramping, and pain. You could also see, obviously, decreased motility and mobility in this condition. They do love asking about your skeletal irregularities, so knowing the difference between lordosis, kyphosis, and scoliosis would be helpful. Lordotic curve, you can see that more often in central adiposity sometimes, just because more weight and pressure, pregnancy. Certain like gymnasts will often have a big lordotic curve. Kyphosis, you can see that concave appearance happen over time. Convex appearance, sorry. Then scoliosis, or lateral curve of our spine. So again, if you're visual, scoliosis, lordosis, kyphosis. Now, naturally, we have a lordotic curve two places in our spine, but this would be an overemphasized lordotic curve. This would be a pathologic or and more extreme lordotic curve. They're not going to ask you for measurements specifically, but they could ask associated with which part of the vertebral column. So what parts of your spine have a natural lordotic curve? It would be lumbar and cervical versus kyphotic would be thoracic and sacral. That's how those questions are often asked. Scoliosis is the condition, though, typically between 9 to 15 is when it's diagnosed, although it could be diagnosed earlier or later. Oftentimes it does run in families. It typically is, there's 3 different kind of types: idiopathic, congenital, or neuromuscular scoliosis. You can have different specific curve patterns. I wouldn't worry as much about the curve patterns as much. More what you're going to be wanting to focus on is potential downstream effects or pathology. So poor posture, obviously pain, differences in leg length, tumors, potential effects on normal growth throughout life, depending on the degree or severity. And in mild, it may not have any pathological outcome, and they might be able to live with it. You could have heart and lung problems, though, and paralysis if extreme. So those would be your common complications. Okay. Moving into more of our rheumatic conditions. So rheumatic and arthritic disorders, there's many, many, many. So we're just going to hit a few of the big ones today. Typically, with rheumatic diseases, there's some immune system involvement and dysfunction. And these are often degenerate. They also have some sort of degenerative wear and tear. And there are some that are more rare and some that are more common. I was just making sure I'm not muted, which I'm not muted, so sorry. Online folks. All right. I haven't been. I've been talking, I promise. Osteoarthritis, the most common form of osteoarthritis. The wear and tear on joints is going to break down our cartilage. You could see maybe a gender kind of difference, but I wouldn't lean your hat on that. Hips, knees, spine, hands. Risk factors, definitely repetitive motion. You can have localized or generalized OA, osteoarthritis. You can have idiopathic or secondary osteoarthritis. But just so you see, you're actually having cartilage breakdown. Big things that are associated with our osteoarthritis are some actual changes to our joints, changes to our actual makeup. And I'm going to see if I have a picture of them here. But it will be worsening over time, worse with activity, better with rest. I'm trying to see if I have my picture up here for you guys. If not, I'll show you. And you can see pain and effects with joints. I'm trying to see. Okay. All right, versus RA. RA is your chronic systemic autoimmune disorder. It's the most common form of autoimmune arthritis. There's lots of different factors involved in etiology, but you'll have antibodies in RA that bind with different proteins and tissues, creating those immune complexes that can cause inflammation. Enzymes then cause further joint tissue and destruction. You'll have localized inflammatory responses. And you can even have osteoclasts that cause underlying bone to demineralize over time. You can see systemic effects like fatigue, anorexia, weight loss, weakness. And you can see rheumatoid nodules that occur, pleural effusion, vasculitis, pericarditis, enlarged spleen. So lots more complications with autoimmune condition. Important kind of diagnostic connection would be your anti-cyclic citrullonated peptide test, or CCP. They might ask about association with that in RA, even though we're technically not diagnosing on this exam. You can also see actual deformities with this condition as well. Our general category of spondyloarthropathies that I want to associate or pull recognition to is ankylosing spondylitis, reactive arthritis, psoriatic arthritis, enteropathic arthritis. And these are interesting because they're related to that H27 or HLA-B27 gene, which, what do we remember about this from the other day? Sorry? PAIR, great. What else? MHC1, right? What's MHC1 recruits? MHC1, rule of 8, CD8, right? MHC1, CD8, MHC2, CD4, because 2 times 4 is 8, 1 times 8 is 8, right? Rule of 8. And it's an MHC1 recruiter because it says one letter. So one letter, HLA-B27, one letter. So it's going to recruit MHC1. It's going to stimulate then CD8 cells to come to those local areas. That's your inflammatory reaction that targets tendons and ligaments, is actually CD8 T killer cell molecules coming there and actually causing apoptosis and breakdown of your own self tissue. So in all these different conditions, they're going to affect certain areas, but I do want you to keep in mind that all of them have this association with HLA-B27. It's such an easy genetic question for them to ask you. So put that in your brain as a pathognomonic. In general, spondyloarthropathies as a whole, pain, stiffness, fatigue. I'm not getting super into clinical characteristics specifically, but the big takeaway would be the HLA-B27 for those. Then our juvenile idiopathic arthritis. There's definitely been some questions on this on the NPLEX before. It's chronic, autoimmune, inflammatory juvenile disorder. Again, same type of symptoms, right? Pain, decreased mobility, swelling. There is some genetic markers that triggers the autoimmune process. I haven't seen this one be specifically asked what its genetic marker is on the exam before. But you can see there's multiple different classifications of this condition. There's multiple different ways it can manifest in a patient. And there's multiple different findings that you could see. So this is where we see a big grab bag of stuff that can become elevated in the body. So ESR, anti-nuclear antibody, rheumatoid factor, anti-CCP antibody. So this would be another one, kind of like lupus, that when in doubt, if there's an all of the above option and they give you a couple you know are right, that might be your correct answer. Also, where I've seen this come into play is they'll ask what conditions can have an elevated rheumatoid factor, and they'll have like rheumatic conditions like rheumatoid arthritis, and then they'll throw this one in as an option. And I think they threw in another random one. They had an all of the above there, and there was one that I had never heard of before, but I knew that juvenile idiopathic arthritis and rheumatoid arthritis could both have elevated rheumatoid factor. So all of the above was the correct answer. That's where you could see this being used. Then we have some of our actual bone density changing conditions. So osteopenia leading to osteoporosis. The decrease in bone density can lead to back fractures, pathologic fractures. Lots of different causes and etiologies to think about. But one of the important ones, eating disorders or even postmenopausal due to lack of decrease of estrogen. That's where I see this being included the most. Glucocorticoids, that would be NPLEX too, so don't think about that yet, but that will come up a lot. But again, your big osteopenia, osteoporosis piece is a pathologic fracture that occurs due to the bone density itself decreasing. Calcium and vitamin D metabolism often come into play. So this is really good calcium and vitamin D absorption questions. So they could rope in some kidney pathology or kidney physiology here. or vitamin D conversion, like we saw some biochemistry. That can be some great associations to make. Obviously, you want to have adequate levels of calcium, vitamin D, and phosphorus in that condition. So if they aren't adequate, you could be at increased risk. And then you have your osteoporosis, osteopenia leading to osteoporosis. Osteoporosis, there's primary and secondary. Primary associated with menopause or decreased bone formation from just aging. Secondary due to something else, like an actual disease. So renal hypercalciuria. So what does that mean? Lots of calcium in the urine. So you are dumping out calcium. You're not absorbing calcium appropriately. Drug processes, which shouldn't be on your NPLEX, but shouldn't be on your exam. Often not diagnosed until fracture, although we do screen for it. But again, you're not diagnosing here. You just have to identify, which is why at this point in the game with pathologies, having a definition of each pathology is what you focus on first. Knowing would be your best bet right now. Then if there's any specific like pathognomonic markers or exam findings that are weird, that would be your second best high yield. And then you could go on and learn the rest of the condition. But really a definition right now should be your best bet to make sure that you at least know what all these mean, all these conditions. You have Paget disease. This is a metabolic disorder that can affect the MSK system. It's going to cause certain bones to overgrow and become weak. So your skull, spine, pelvis, and femur. Really important bones. You'll have bone reabsorption that occurs faster than newborn bone formation. So the bone then compensates by trying to accelerate creation of new bone, which the new bone that they put on there is weak, brittle, and fractures really easily. So that's the big piece with Paget's, is to recognize that bone reabsorption is occurring quicker than bone formation. So the body makes more bone, but that bone it makes is not strong bone. It's weak bone, brittle, and it breaks. And that's all we have for chronic for today. We're going to get into acute, and then we'll close up the day. That was MSK chronic for those online. MSK path is the acute PowerPoint. Again, I have decreased or deleted some slides from all of these presentations. Some more acutes. Learning your fractures would be a good idea if you don't know them now. Some fracture questions tend to be on the exam in some way, shape, or form. Understanding its relationship, again, with bone health, vitamin D, calcium, phosphorus. That's when I see these fracture questions included the most. Maybe they'll give you a question about Paget's disease and talk about the bone is brittle and then say you have a pathologic fracture of this kind. And they'll ask about fracture types. Or they'll ask about healing stages. This has definitely come through before. So with healing of fractures, that's why I'm going to spend a little time on it. You have your indirect healing, which occurs with an inflammatory stage. Your bleeding is going to cause a hematoma, blood collection. You're then going to have all those good inflammatory cells, your macrophages, your dendritic cells, your neutrophils, your lymphocytes are going to come and degrade debris and bacteria, any bacteria that's present. You then move into the reparative stage where you create fibrocartilage and a soft callus. And then you're going to develop a hard callus, and then you get blood flow back to the area, the region. And then you start remodeling where you actually get lamellar bone that replaces the woven bones. That's your final kind of remodeling stage. In indirect healing, you can have 4 different things that can occur: union, non-union, delayed union, or malunion. Union is normal. Non-union means that essentially you're not putting those 2 bones back together for at least 3 months. Delayed is it's taking longer than you'd expect. And malunion, it's not correct. Okay? Any of these can occur. Depends on the type of fracture, the location of fracture, adequate blood flow to the area, how severe the fracture was. And then direct healing is different. It's using surgery, so we're not going to worry about that. Complications of fracture. There was a couple compartmental syndrome and some bacterial infection questions on NPLEX in the past for fractures. So for infection, common fracture infections is Pseudomonas, Staph, and Clostridium. So if we remember, our Staph is a gram positive, our Pseudomonas is a gram negative, our Clostridium is a gram positive. Staph is found on skin. Does that make sense? Pseudomonas, it's just one of those big batters that's not super fun. So if it gets a chance to infect, it's going to really cause some problems. Clostridium tends to hang with it's a coccyx, cocci, I believe. There's a rod. It's a cocci. No, I'm gonna lead you astray. Let me confirm. Gram positive, yes. Huh? It can form in spores, yes, just like bacillus. I just don't want you to lead you astray since I started talking about things. That's always what I do. Rod, yep, that's why I wanted to check. Clostridium rod, Staphylococcus cocci, both gram positive. Clostridium spore, Pseudomonas negative. Compartment syndrome is the other big complication. So infection and compartment syndrome. Compartment syndrome, big issues, obviously edema, swelling, decreased blood flow, and then long-term muscle and nerve damage to the area. That can all lead to ischemia. If there's increased swelling to the point where you're unable to get blood supply in, then you can get ischemia to the area, and that's when it gets concerning because the muscle and nerve can die. That's when you could have to lead to amputation. And this is your little picture of compartment syndrome. Most common sites is lower leg and forearm, so areas where there's an actual compartment, right? Other ones are less common, but I'd say the most important one here would be fat embolism. This would be more important for like a closed long bone, like a femur or a pelvic fracture. Typically, you have no symptoms in most patients, but it can cause the same symptoms as a pulmonary embolism or DVT, depending on the location and where it kind of messes up the system. And then you have your dislocations. These are all categorized as your acute traumas in your NPLEX section under MSK. Most of the time when talking about dislocations, they're talking about them in association with what nerves or other surrounding structures may they affect, or what blood flow could get cut off. That tends to be how dislocations are discussed on an NPLEX exam, if they're discussed at all, or associated with like small bones of the hand. They might dislocate one of those for you and say what bones are going to be on either side, right? Potentially affected, or what potential compartment could become entrapped then, what nerve could be affected. That's when I tend to see the dislocation questions brought up. So carpal tunnel syndrome or cubital tunnel syndrome. So carpal tunnel is on your NPLEX, medial nerve entrapment, localized at the wrist. You can have ulnar tunnel syndrome. So this is not the only nerve entrapment place that can occur. We will talk more about nerves next week or tomorrow or Thursday, whatever day we're talking again. But carpal tunnel syndrome is a good one to know. You don't have to diagnose them yet, but you'll learn this for osteos at some point if you haven't already learned it. All that good stuff. And then I want to just take a minute to just reiterate strain and sprain. This one, you would be surprised how many people mess this up on the NPLEX. So strain, muscle, sprain, ligament. All right. Again, strain, muscle or muscle tendon, sprain with a P, ligament, joint. Okay. Don't mess it up. Muscle strain, ankle sprain. It's just like one of those things that enough people have messed up that I had to include it. I'm skipping the knee. And I'm going to go to the rotator cuff. Rotator cuff tears, this is when they want you to know the muscles of the rotator cuff. So that's when this comes into play. Is the rotator cuff tear, what muscles could be affected, and they'll list out muscles that are involved and not involved in the rotator cuff. You have to choose which ones are or which ones aren't. And then this condition tends to be on there because there is some association sometimes with people who have type 2 diabetes with adhesive capsulitis or frozen shoulder. But it's essentially acute inflammation in that and the ligaments of the shoulder joint capsule. You're unable to move your shoulder all of a sudden for really no known cause or reason, but there is some association with metabolic conditions like diabetes. It will self-resolve. So the complications would be typically nothing. Typically it has self-resolution even without treatment over the course of 2 years, or you might have minimal loss of shoulder function. And then lastly, impingement syndrome really comes into play when we're talking about certain nerves or muscles that could compress things. So this really comes into play with anatomy again, and not anatomical conditions. But typically it's some type of muscle or bone or structure compressing a nerve, causing neuropathy. Last but not least, or it might not be last but not least, but osteomyelitis, a bone infection, typically occurs after some type of penetrating external wound. So bacteria that lives on the surface are often the most opportunistic that can get in there. But it could be from bacteria, fungi, parasites, or viruses. Could also be carried via blood to bone. Your clinical manifestations, obviously deep bone pain, but you can have full body response. Staph aureus being one of the big ones. And if it's not treated, or if there's not adequate blood supply, you could get osteonecrosis or avascular necrosis or aseptic necrosis, ischemic necrosis. Essentially, all of these, blood loss to the bone. Not good. Bone breakdown will occur faster than replacement then. Some of your risk factors would be steroid use, alcohol, injury, treatment for cancer, chemoradiation, organ transplants or disease. You might have no pain. You might have a lot of pain. What's our big concern for a Fuchs injury with avascular necrosis? Does anyone know? Scaphoid, yeah, why? There's only one blood supply to that bone. So if you have a Fuchs injury and you fracture that area and you cut off that blood supply to the component, one of the components fractured, especially if it's fully through, you could get avascular necrosis if you don't have adequate repair, because the body doesn't have blood supply to one of those pieces. So that's oftentimes when we see that one come up, if they're going to include a osteonecrosis question. A Fuchs, fall on an outstretched hand. A Fuchs injury. You could, boxer fracture could, yeah, absolutely. Fuchs though, because you land like right on it. Yep. Your bone tumors, again, if this is not your area of expertise, I would not spend a lot of time on bone tumors. So I'm going to personally skip it. But no metastatic bone disease, obviously anywhere, cancer from any site can migrate to the bone, but most common places you'd see it is your spine, your pelvis, and your thigh. And on that note, we are through major MSK pathology. We are to 12 o'clock. It is time to be done. Tomorrow, you'll be on your own studying. I suggest that you go through and do some looking into what you haven't hit yet. Look at what you still need to cover in your study schedule. Start planning your next week's study schedule. Thursday, we will do neuro. So all of Thursday is going to be neurology, anatomy, physiology. We'll do a little embryology and some path. And then Friday, we're going to hit a little bit, it'll be kind of some popcorn on the areas we haven't touched base on. So integumentary, a little bit of reproductive, and a little bit of hematopoietic. But we've done a lot of blood already. So just be a few things on each section for Friday. Thank you. Bye. Nice job.
Dr. Petra, I have a quick question.
Yes.
I have two quick questions. One is there were a lot of questions on iron in the sample test today. Are there others like sequences or minerals that you would recommend us looking at in terms of like frequent, like the high yieldness of because there's just so many.
Yeah, there's so many. I would say iron would be a big one, and if you had to choose one other, maybe vitamin D. But iron is probably the biggest. And innervation and action is what I'd focus on for muscles, Kristen. And then origin and insertion will be later, but there'll be some specific muscle questions, and you'll get a few of them right, and some of them you'll get wrong, unless if it's something that you really know. Yeah. Awesome. Okay. Great. Hey.
And I have a second question. Dr. Pecho?
Your question. I have someone else asking a question here, so one moment. No, you're